Hello, I'm Chris Rogers. I'm a physiatrist in San Diego, California. I would like to thank Steve for the opportunity to share the work our team is doing with MSC therapy for patients with COVID-19. Last year at the TOBI conference in Chicago, I told you about our FDA-approved clinical trial for knee osteoarthritis. Well, we were halfway through the completion of that study when the coronavirus pandemic started. As you're aware, COVID-19 is caused by the novel coronavirus SARS-CoV-2, which infects cells when the viral spike protein binds with an ACE2 receptor. These receptors are found mostly in the respiratory tract, but are present in several other organs as well. As a result, patients can present with a myriad of symptoms and complications. The vast majority of confirmed cases will develop mild symptoms, yet 14% are severe with pneumonia and respiratory distress, and another 5% develop critical illness with respiratory failure, septic shock, and multiple organ failure. Globally, coronavirus has infected more than 7 million people and over 400,000 have died. With a worldwide case fatality rate of 5 to 6%, COVID-19 is not as severe as SARS or MERS epidemics, but much more lethal than influenza. Risk factors for severe illness include age and medical comorbidity, such as hypertension, diabetes, and cardiovascular disease. Common features of severe COVID-19 include pulmonary infiltration of monocytes, neutrophils, and macrophages, lymphocytopenia, elevated pro-inflammatory cytokines, delayed interferon gamma response, vasculitis and hypercoagulation, which causes multiple organ damage, and acute respiratory distress syndrome. In COVID-19 patients, ARDS results when neutrophils and monocytes invade the alveolar spaces, leading to epithelial and endothelial cell apoptosis, increased vascular permeability, alveolar fluid accumulation, and pulmonary fibrosis. And currently, there are no proven treatments for ARDS. Mesenchymal stem cells, also known as medicinal signaling cells, may prove to be an effective therapy for patients with COVID-19, as they are known to possess several therapeutic mechanisms of action. These include the MSC's ability to sequester within the lung when infused intravenously. MSCs are immune evasive. They secrete anti-inflammatory cytokines. They modulate the immune cell responses. They secrete extracellular vesicles. They are antibacterial, antiviral, and anti-apoptotic. They promote alveolar fluid clearance and pulmonary tissue regeneration, and they inhibit pulmonary fibrosis. We think that the optimal time to use MSCs is when respiratory distress or abnormal immune responses first develop. A systematic review and meta-analysis in preclinical animal models of acute lung injury have confirmed that MSC therapy was able to reduce mortality. Several systematic reviews and meta-analyses of human clinical trials have demonstrated impressive safety of MSC therapy without serious adverse events for multiple medical conditions. Safety in ARDS has been demonstrated in Phase 1 and Phase 2 randomized clinical trials that use bone marrow-derived MSCs, as well as adipose-derived MSCs. And there have been a number of clinical cases conducted in China and Israel that show preliminary evidence of safety and efficacy when umbilical cord or placenta-derived MSCs were used in COVID-19 patients. However, these studies were not matched by age, gender, or medical comorbidity. Several of our esteemed colleagues published this systematic review and meta-analysis of MSC therapy for the treatment of patients with ARDS. 9 studies with 200 patients were analyzed, and after excluding one study with a poorly matched cohort group from the analysis, the mortality rate was 49% in the control patients with ARDS, compared with only 16% in the MSC-treated patients. Worldwide, there are more than 45 clinical trials of MSC therapy enrolling patients with COVID-19. In the US, only 5 investigational new drug applications for MSC therapy have been approved by the FDA, and a few expanded access applications have been approved as well. We expect to obtain FDA approval for our Phase 1 safety trial this week and intend to start enrolling patients soon thereafter. We will enroll patients with PCR-confirmed COVID-19 pulmonary distress and treat them with an IV infusion of allogeneic adipose stem cells manufactured at our FDA-inspected GMP facility in San Diego, California. We will monitor them for adverse events, respiratory function, inflammatory biomarkers, and clinical outcomes. We are excited to get started, and I look forward to sharing the results of our study with you soon. To learn more about this promising therapy, please take a look at our published scientific review in the Journal of Translational Medicine or visit the website listed below. Thank you very much for your attention.